Adult midshaft clavicle fractures, are we fixing too many? I'm Jesse Seamon. I'm an orthopedic surgeon in Roanoke, Virginia. I work at Carilion Clinic, and I'm the program director for the Virginia Tech Carilion Orthopedic Residency. My co-authors are Devin Peckus and Alex Garcia, who are our research fellows this year. A little background on the clavicle fractures. These are common. They account for about 2.6% of all fractures. The most common location is the midshaft, which is about 80% of the injuries, and the next most common area is the lateral third, which is 20%. The medial third fractures are rare. The treatment for clavicle fractures has traditionally been non-operative, with historic literature indicating good results with non-operative care. Treatment options: non-operative treatment or operative treatment are the two choices. So for non-operative treatment, for me, that's a sling for 2 to 6 weeks, and I allow for motion as soon as the patient's comfortable. There's no benefit to a figure of 8 bandage over a sling, and that's been borne out in the literature. Operative treatment: we've seen a massive increase in operatively treated clavicle fractures over the past 25 years, primarily due to better implants and also studies showing 15 to 20% non-union rates with non-operative care. For me, when I do operative treatment, I use a plate and screws, either superior or anterior, just depending on the fracture pattern. So I want to do sort of a brief literature review to just look at the evidence we have for fixing versus not fixing clavicle fractures and sort of really analyze what's out there. Before we do that, I think we should talk about the DASH score and the constant score. These are the two scores that are commonly used in the literature, and so I think it's worth just going over them briefly. The disabilities of the arm, shoulder, and hand score is the DASH score. It scores 0 to 100, with higher being worse. It looks at subjective disability with physical function, pain, social and emotional impact. And the minimally clinical important difference, or MCID, for that is around 10. The constant score is primarily looking at shoulder function. It scored 0 to 100, with higher being better. One of the main differences between the DASH score and the constant score is that it also looks at range of motion and strength, so it has some objective measures. And the MCID for the constant score is around 10 to 20. So I want to just touch on one other thing before we start looking at some of these studies, and that's the minimal clinically important difference, or the MCID. What this is this is the smallest improvement in a patient's condition that they perceive as beneficial. So results that are less than the MCID are not clinically significant. So you could do a study where you had a statistical difference in the scores. For example, for the DASH, you could have a statistically significant difference of 4 for the DASH at all time points. And so even though one group has a statistically significant difference in the DASH score, if the difference is less than the magnitude of the MCID, which is 10, then it's not considered clinically significant. So when you're looking at these studies, you can't just look at, are the scores statistically different? You have to actually look at, does the difference in the scores actually meet the MCID threshold, where it's going to be clinically significant to a patient. So we'll talk about that as we look at some of these studies quite a bit. I think the first study to look at, and probably the most famous study, is the 2007 JBJS study by the Canadian Orthopedic Trauma Society. This was a randomized controlled trial looking at operative versus non-operative treatment for young adult, highly displaced midshaft clavicle fractures. The study had a pretty large impact. I was just getting ready to start residency when it came out, and it was often talked about, and so it had a pretty big impact, I think, around the country. The authors concluded that RIF was superior to closed care for young adult clavicle fractures, and they did show a higher DASH and constant score at all follow-up time points. But diving into it, the difference met the MCID threshold probably just at the 6-week point. So looking at the study in a little more detail, I think looking at the demographics, these were young patients, so the average age was 33. They looked at highly displaced fractures, that the average fracture displacement was about 2 centimeters. I think it's worth noting that there was a pretty high smoking rate in both groups, so 30% of the patients in each group were smokers. And there was more women than men in the non-op group, so 32% of the patients in the non-op group were women and 14% in the operative group were women. So you had a significantly higher number of women in the non-operative group compared to the operative group. And there was a study in JBJS by LaRue et al. In 2014, which was, of course, after this study was done, but they looked at 1,300 patients, and they did find that female sex was an independent risk for non-unions. That's a possible source of higher non-union rate in the non-operative group, but it's hard to say that definitively. Looking at their data, which their main functional result was the constant and dash score at 6, 12, 24, and 52 weeks. So I think just looking at this, you can see with the operative group is the solid line, the non-operative group is the dashed line. And when you look at this, you can see that at 6 weeks, there's a clear functional benefit to surgery versus no surgery. So the difference between the constant and dash scores is greater than 10, and that indicates a clinically significant benefit. When you start looking at the 12-week and the 24-week time points, you can see that that difference between the two scores gets smaller. The scores for the surgical group are better, but the actual magnitude of that difference is less than 10 based off what I'm seeing on the graph data. And a difference less than 10 does not meet the MCID threshold. And so even though the functional scores, are quote unquote better at 12 and 24 weeks, it doesn't actually meet the MCID threshold. So what I'm seeing here, I would say that at 6 weeks, we can see there's a clinically significant functional difference. At 12 and 24 weeks, although there's a difference in the scores, with the operative group having better scores, so to speak, that difference doesn't meet clinical significance. So what I'd conclude, based off their study, is that there's a 14% non-union rate for non-operatively treated fractures versus 3% for operatively treated. The dash and constant scores show a clinically significant improvement at 6 weeks for the surgical group compared to the non-surgical group. I do not see a clinically significant difference at 12 and 24 weeks in terms of the dash or constant score, since the MCID is less than 10 at those time points. For young patients with highly displaced midshaft clavicle fractures, surgery provided no clinically significant difference at 12 or 24 weeks in terms of the dash and constant score, but it did provide a significant benefit at 6 weeks. Looking at a number of clinical trials performed between 2010 and 2020, which a lot of these trials followed the COT study in 2007, essentially they all showed relatively similar things. There was a non-union rate of 15 to 20%. There was generally a clinically significant functional difference at around the 6-week time point, but that clinical significance faded by 12, 24 weeks in a year. And so I think these studies showed relatively similar findings to the COT study, although the conclusions were sometimes different. Some of them concluded there was a benefit to surgery, some of them concluded that there was no benefit to surgery because the functional scores didn't meet clinical significance. I think the one thing that really stands out, though, when you're looking at all these trials is the non-union rate, which was pretty consistently around 15 to 20%. A more recent study in American Journal of Sports Medicine in 2019 by Garrett et al. Looked at 14 different randomized controlled trials encompassing over 1,500 patients. And again, this showed similar findings. So the dash and constant scores were better for the operatively treated patients versus the non-operatively treated patients at short, midterm, or long-term follow-up, but the magnitude of that difference did not meet the MCID threshold at any time point. So even though we're seeing a quote-unquote better score, it isn't reaching clinical significance at any time point. There was a 31% rate of complications in the surgical group. Most of these complications were harbor irritation requiring removal. Serious complications were actually very rare. And they did find that the surgically treated fractures healed about 5 weeks faster on average than the non-surgically treated fractures. I think they did a very good meta-analysis, and my conclusion based off their data is there's no significant functional or clinical difference between surgical and non-surgical treatment past 6 weeks. A much more recent study in Journal of Shoulder and Elbow Surgery International in 2024 by Kivist et al. Looked at 10 randomized trials encompassing over 1,300 patients and essentially found the same thing, which is that there was really no clinically significant benefit past 6 weeks in terms of the dash or constant score for operative versus non-operative. Looking at the literature in terms of the risk factors for non-union, because I think that's what we're really trying to avoid here, smoking has been clearly shown to be a risk for non-union. Continued pain and poor function 6 weeks after injury is another risk for non-union. This was nicely demonstrated by Michael Robinson et al. In JBJS in 2020 and 2016. They looked at 200 clavicle fractures managed non-operatively, and what they found was that patients at 6 weeks that had dash score greater than 40, keeping in mind that higher is worse, no callus on x-rays, and fracture motion on exam had a very high non-union risk, which was greater than 40%, whereas those patients with a dash score less than 40, visible callus on x-ray, and no fracture motion on exam had a low non-union risk, less than 3%. One other risk factor for non-union is fracture characteristics. Murray et al. In JBJS 2016 looked at about 1,200 clavicle fractures treated non-operatively, and the risk for non-union were fracture comminution and displacement greater than 2 centimeters. What does the literature tell us about complications from surgery? Essentially, the rate of serious complications like non-union and deep infection, pneumothorax, brachial plexus injury are rare. Those are rare. But the rate of harbor irritation is very high. And it ranges in the literature from like 10 to 40%, but harbor irritation is a common complication and it requires implant removal. And it almost averages out to 20 to 25% when you look at the study. So there is a significant number of patients that are going to get a secondary procedure here for harbor removal, or at the very least be irritated by the hardware. So that's something to really consider when you're fixing these fractures. What have we seen in terms of trends for clavicle fracture fixation? Basically, we've seen a massive increase. California, New York, over 300%, Sweden over 705%, Finland a tenfold increase. Looking at ABOS Part 2 candidates between 1999 and 2010, there was a sevenfold increase. So we've clearly seen that the number of clavicles being fixed has increased a lot over the past 25 years. I would attribute this to better implants and literature showing the high non-union rate, which I think has spurred people to action for a lot of these fractures. How I would summarize the literature is as follows. Midshaft clavicle fractures have about a 15 to 20% non-union rate when treated non-operatively. Functional scores, specifically the dash and constant, do not show a clinically significant difference beyond 6 weeks with surgery. Serious complications with clavicle surgery are rare, but need for harbor removal is common. Based on the general rate of non-union, you would have to fix about 7 clavicle fractures to prevent 1 non-union. We've seen a massive increase in the number of clavicle RIFs over the past 25 years, owing to better implants, and I think the literature showing that what the non-union rate truly is with non-operative care. So what do I recommend? Well, my main treatment goal, based off what I've read in the literature, is to avoid non-union. We know that rate's about 15 to 20%. I treat all uncomplicated midshaft clavicle fractures initially with non-operative treatment. So I place them in a sling, and I let them move their shoulder as soon as they're comfortable, which usually takes around 2 to 4 weeks. I see everybody back at 6 weeks and do a repeat assessment. And I sort of base that roughly off the criteria laid out by Robinson et al. In the 2016 and 2020 JBJS articles. So I get an x-ray and I look for callus. I do a physical exam and I see if there's any motion to the fracture. And then I talk to the patient and see how they're doing subjectively. How's their pain? Are they weaned out of their sling? Are they doing their ADLs pretty comfortably? For the patients that are sort of hitting all those markers, in other words, they have callus on x-ray, they've weaned out of their sling, they don't have fracture motion on exam, those patients go on to heal, and I continue treating them non-operatively to union. For the patients that are doing really poorly at 6 weeks, so the patients that you look at the x-ray and there's no callus, on exam you can still feel the fracture motion. Subjectively, they're not happy, right? Like they can't get out of their sling or they can't move their shoulder because it hurts too much, they can't sleep at night. For those patients, I offer them surgery because I think at that point their non-union risk is significant and we can likely prevent a non-union by doing a surgery. The literature actually suggests a pretty wide range of union times for non-op treatment, and I think it's relatively consistent that people that get surgery heal a little bit faster than people that don't, probably about a month average faster overall. But what I've observed is that for the patients treated non-operatively, by 12 to 20 weeks, they're usually healed. And almost always by 12 weeks, they've got significant callus on x-ray and no fracture motion on exam. So that's kind of what I've seen. If I do surgery, I always use a plate and screws. I don't use an IM device, although the literature has shown no difference in terms of union rates between either. I don't think there's a difference between a superior and anterior plate. I just use whatever's better for the fracture pattern. There's been a couple studies that showed no difference in harbor irritation rates between superior and anterior plates, and I think we had one of those up on the slides earlier. There is a couple times I'll consider more acute surgery, and that's kind of based off the criteria that I'm sort of listing at the bottom of this slide. So if I have a fracture that's widely displaced, greater than 2 centimeters, or it's highly comminuted, or it's significantly overlapped, and there's a pretty severe cosmetic deformity, I'll sometimes offer acute surgery for those patients. If there's severe or significant skin tenting, if there's an open fracture, certainly that is offered acute surgery. Patients that have multiple rib fractures, especially where rib plating is planned by our general surgery colleagues, will usually offer surgery to. Someone with a brachial plexus or a vascular injury can usually benefit from surgery. And then the final one is someone that has multiple lower or upper extremity injuries where early use of the arm is preferable. That's a reason to consider surgery as well. So in conclusion, clavicle fractures are very common. I think that the majority can be successfully treated without surgery and use of a sling for 2 to 6 weeks. There is certain select patients and situations where patients will be better off with surgery, and it's important to try to identify those individuals. Treatment of displaced clavicle fractures is individualized, and it's a patient-specific decision. There's no one-size-fits-all treatment. What I would say is that if you're fixing every displaced clavicle fracture you see, you're probably fixing too many. But I also think that if you're not fixing any displaced clavicle fractures you see, you're not fixing enough. So the best treatment's somewhere in the middle, and the best way to make that decision is to talk to the patient and, where possible, delay that decision out to 6 weeks to see how they're doing overall. Thank you.